Good afternoon. It is so great to have everyone here for our first lecture of 2020. I hope you notice on our slide our lecture series coming up. And yes, indeed, in just in 2 weeks, we have our next ethics lecture. So we are typically on the first Wednesday of the month, but in January, it is so hit and miss with weather and schooling. So that's why we are here on this later date. But we are so glad that you are here. I'm Robin Axel Adams, the manager of the Fairbanks Center for Medical Ethics. We invite you and encourage you to sign in. It not only helps us keep track of attendance, but also is the way that you can get your CE and CME evaluation. Know that you will get that evaluation at the end of our series, so at the end of May, and then you can evaluate and get your certificates. This lecture is being broadcast and recorded today, so we want to give a hello and thank you to IU Health Ball and Blackford, North and Arnett. And the School of Dentistry is joining us, Reed Health, and Clark Memorial. So welcome, and welcome to anyone who is also watching this later. A reminder to silence your cell phones. If you need to talk to someone, please do leave the auditorium. And Dr. Hickman has no financial things to report. All right, so now that we have all that out of the way, let me also invite you, I guess one more thing, that we do have our Lunch and Learn coming up in a couple of weeks if you want to learn about our ethics fellowship, so you can join and take a deep dive into ethics. So it is my great privilege to introduce Dr. Susan Hickman. Dr. Hickman often comes and teaches to our ethics fellows and is one of our senior affiliate faculty here at the Fairbanks Center. But she is a geriatric psychologist and a professor at the Indiana University School of Nursing and the School of Medicine. She's also the director of the IU Center for Aging Research at Regenstrief Institute. She's been educating and conducting research on advanced care planning for over 20 years. Dr. Hickman is currently funded by the National Institutes of Nursing Research and the Retirement Research Foundation to evaluate the quality of advanced care planning decisions in the nursing facility settings. She's also a co-PI on a National Institute on Aging, I practiced this and it still didn't work, pragmatic randomized clinical trial to evaluate an ACP Specialist Program for people with Alzheimer's disease and related dementia who live in nursing homes. Service activities, including Associate Director of the Indiana Patient Preferences Coalition, and she is also the chair of the National POLST Research and Quality Assurance Committee. And so it is such a great honor and a privilege to have Dr. Hickman come and join us. Thank you.
Thank you, Robin. Good afternoon, everyone. See if I can get oriented here. I was expecting a keyboard, but I get a clicker. That may or may not work. Suggestions? There's like one option. I don't think I'm missing something. Keyboard. No, it doesn't want to advance. There. And I hit it like 6 times, so if it suddenly zips forward, we'll know what happened. So I'm really pleased to be here this afternoon and really appreciate the invitation and the opportunity to talk with you about different activities related to advanced care planning that are happening in Indiana right now. And today I'm going to cover 3 different areas. The first is focused on legislative changes, both recent and pending, that are relevant for advanced care planning in Indiana. I also will share updates from the National POLST Program, and I'll talk with you a little bit more about that if some of you are scratching your head about what that means. And then I'll also describe some research that's related to advanced care planning and POLST decision quality. So you'll get a little bit of everything today. I don't presume, however, that this is reflective of everything that's happening, and I know there certainly is a lot of work within IU Health and within the community that is not going to be reflected in my comments, but I did want to acknowledge that there are a lot of people who are really passionate and dedicated and working hard to improve advanced care planning and ensure that people's preferences, values, and goals are honored, particularly at the end of life. So the first thing I'll share with you is that between 2016 and 2019, there was a legislatively authorized group called the Indiana Palliative Care and Quality of Life Advisory Council. And I had the honor of being appointed chair of this council and had really interesting experience working with both our pretty amazing council members as well as stakeholders who volunteered to participate in the work of the council as we strove to identify what were the most important issues related to palliative and palliative care and quality of life within the state of Indiana, and identify both policy and regulatory changes that might address these issues. And so this council met between 2016 and 2019. We met every other month. We identified 3 areas that we were particularly focused on. The first one was on access to palliative care. The second focused on pain management and access to pain medication. And the third was on advanced care planning, which probably shouldn't have been a huge surprise since I was chairing the council, but it was important and everyone agreed. And I just gave them to you in reverse order, but that's fine. So the first year we identified those 3 focus areas, and then we convened work groups around each of those areas, and we pulled people together and helped brainstorm together and tried to identify what were the most significant issues and what were potentially regulatory fixes for them. And then in the final year, we reviewed all of those recommendations and put forward a series of recommendations from the council that stand as our official recommendations, and that was submitted in June of 2019. What I'm going to focus on today is related to the advanced care planning area. And specifically, we had 4 recommendations that came out of our work together. The first was to revise the Indiana Living Will or Advanced Directive statutes. The second was to support development of a registry for advanced directives and POST forms, physician orders for scope of treatment. The third was to encourage additional data collection element to support quality improvement activities. And the fourth was around supporting advanced care planning education and training for healthcare professionals. So at the end of the day, this is where we landed related to advanced care planning. And we thought the ones that were most feasible to move forward were the 2 that are highlighted or in bold print. Just for those of you unfamiliar with our current advanced directives, we do have advanced directives on the books, and advanced directives is an umbrella term for lots of different kinds of decisions you make in advance. Specific to end-of-life care, we're typically talking about a statement of preferences that's commonly known as a living will. And then the identification of a legally appointed representative or a surrogate decision maker. So those are 2 kinds of advanced directives that are most relevant to end-of-life care. In Indiana, we're a little bit different. We have 2 ways to express your preferences. You can either fill out something called the Indiana Life Prolonging Procedures Declaration, which basically says if at any time I'm close to death, then do everything for me. And then we have this living will declaration. And this language was developed through statutory processes about almost 30 years ago. And it says if at any time my attending physician certifies in writing that 1, I have an incurable injury, disease, or illness, 2, death will occur within a short time, and 3, the use of life prolonging procedures would serve only to artificially prolong the dying process, I direct that such procedures be withheld or withdrawn, and that I be permitted to die naturally, with only the performance or provision of any medical procedures or medication necessary to provide me with comfort care or to alleviate pain. And then if I've so indicated below, the provision of artificially supplied nutrition and hydration. So if you want to have a statement of preferences and just your own wishes in Indiana, it needs to legally include this language. Right? So this is in our statutes, it is the required language. You could add it to another document. You could, expand upon it. You can add 30 more clauses to it if you want, but this is our standard language. And it really reflects, I think, the era in which it was created. There are a lot of challenges with the language, and we have learned, a lot about advanced care planning over the last 30 years. I've highlighted some of the terms in here that are particularly problematic. Like, what does it mean to have an incurable injury, disease, or illness? Additionally, even this idea that an attending physician is going to certify in writing, everyone I talk to says that never happens. There's language in here that's a little bit antiquated and not necessarily helpful in the clinical setting when the time comes for this document to be called upon. Additionally, right now we have two ways to legally appoint someone to be your healthcare representative. And this is a little bit of an oddity that we have two mechanisms. There is the healthcare representative, which requires a witness, and you can cancel that orally or in writing. And then we have a healthcare power of attorney, which requires two witnesses and notarization. And if you want to cancel the appointment of your healthcare power of attorney, you have to do that in writing. And you can't just fill out a healthcare representative. If you have a healthcare power of attorney, the healthcare representative appointment form is worthless. So they're a little bit challenging because the standards for how they get completed differ. The ways in which you revoke or cancel them differ. And actually the scope of authority is a little bit different. Broadly stated, the healthcare power of attorney has more authority over a broader range of decisions, but the differences between those two are not well understood. And I think there's a tremendous amount of confusion around this. I've been doing education around the state for the last 10 years since I came to Indiana. And this is a constant source of befuddlement in clinicians. Additionally, it's a source of confusion among just your average, patients and family members. Family members will say, well, I have a power of attorney. And they'll bring it in, when asked, and it turns out it's for finances, not for healthcare, right? So there are a lot of complexities around this. It's sort of, and the reality is the reason it's complicated is actually almost, first of all, it's no longer relevant, and it's also kind of humorous. I have been told the history of this is that we originally had the healthcare power of attorney, and it came in this 10-page packet that the state health department issued. And there, about 15 years ago, the hospitals started to complain about the volume of paper in the charts. This may even be 20 years ago. So when we were still using paper-based charts, this big packet was really sort of adding, right, to the paper burden. And so they came up with this healthcare representative appointment that was simpler to do at the bedside, could just be a page, and was much more straightforward. So, and there were lesser witnessing requirements, right? So it's easier within different settings to actually execute one. We are, to my knowledge, the only state that has these two different ways, and it's really just this artifact of this strange evolution. It's not from some deliberate, intentional reason. So there is now currently a real interest in making changes to our advanced directive statutes. And as I indicated, this was actually one of the recommendations of the council. So we convene work groups, and as we talk through these different issues, it was clear that first, this group of people who were stakeholders, who represented key constituents, instantly recognized how confusing it was, and started talking with their constituents and learned that people really were dissatisfied with some of the limitations of the tools. So there is now a bill that's pending that will actually make, if it passes, some changes, some pretty important changes to our statutes. And the reasons are, I've already articulated some of them, but we do have conflicting statutes. And in fact, the three statutes that authorize the healthcare representative, the living will / life prolonging procedures declaration, and the healthcare power of attorney are three different statutes. So they like cross-reference each other, and there are all these like confusing things. Like if you try and read them, you have to go here and then there. There are inconsistencies that have developed over time. There are gaps in them. And there are some places where it's just flat out confusing. And you can put a group of attorneys in a room for hours and they can't come to agreement about what you're supposed to do in a specific situation or what it means. Now, there's no guarantee that you could ever eliminate different interpretations, but it is particularly complicated because of the evolution of these statutes. Additionally, there are unclear decisional standards for legal representatives. So one of the most common questions that I hear about, and particularly comes up in ethics consultations when you have a legally appointed representative who's making decisions that appear counter to what that patient had indicated themselves. And really the statutes are not clear about what those standards are. And then the other piece that I think, often that I'm acutely aware of is that because we have these sort of antiquated documents, that are a little clunky to work with, it really has inhibited innovation. There are many groups around the state, community-based groups, who are working to improve advanced care planning, and they have over the last many years, I've heard from these groups who feel really like their hands are tied with our clunky living will. They want to be able to use some of the innovations and developments that have been happening nationally across the country for the last 20 years, but they don't meet our legal standards. So you can't just import them and use them. So this is a challenge as well in terms of promoting practice and supporting innovation. We have instead limitations because we are tied to this language that's embedded in the statute. You can work around it, don't get me wrong, but it is a source of frustration and unnecessary complexity when there are lots of really cool tools that are evidence-based that would be really great to use. So the bill that is being proposed would combine and simplify those three statutes that I referenced. So instead of three different places, it would consolidate all of the language into one clean bill. It is not a short piece of draft legislation. It's about 30 pages, right? There's a lot of ground to cover, but it would simplify what we have. It would establish just one mechanism to appoint a legal representative with clear standards of conduct. And specifically that these representatives would be required to act based on that patient's expressed or implied preferences. That would be a huge change. And then it would establish general standards for signing. So it would require that any kind of advance directive, a statement of preferences like a living will or the appointment of the legal representative would require either 2 adult witnesses or notarization. And this signatory standard is actually much more consistent with our neighboring states and the norms across the country, which makes it a lot easier for us to then use the tools that have been developed across the country within the state of Indiana. We actually have been talking about this for a while, and in the last session in 2019, Representative Cindy Kirkoffer from Beech Grove co-authored a bill with Representative Hatfield to make modifications. It was House Bill 1516. There were a lot of questions about it. I think we were a little, later than we would have liked in getting key stakeholders to the table. And so that actually didn't advance. But we reconvened these groups this summer, and I have Representative Kirkoffer with question mark because they are likely going to be adding people. And now we have Bill 1317, which would create just one Indiana advance directive. It would have this healthcare representative appointment and standards about what counts as an advance directive, including a statement of preferences. And basically, it's a statement with 2 adult witnesses or notarization, right? Much cleaner and simpler, and again, much more consistent with what we see nationally. So this bill was just, I heard it, I think it dropped is the language today. The only thing about the bill is there's still some cleanup. There have been some, continued discussions, and because of details I won't bore you with, but they had to move forward with the draft that we had a couple weeks ago to go through the legislative services. And so the bill that's now been officially listed still needs some minor adjustments based on comments and conversations that we've been having with a big group of people through emails. So there are a few changes that need to be made, but it's pretty close. And we are excited. I think some of the challenges we had in talking through the specifics of the bill. So one of the really interesting things that became apparent was that a lot of the attorneys that we encountered were not familiar with some of the provisions of the healthcare power of attorney statute. So the healthcare power of attorney has always allowed a person to appoint more than one person to be their power of attorney for healthcare, and they can require that they work together. And so when this appeared in this new bill, there was a lot of questions like, oh my gosh, that's like such a headache. And yes, it is such a headache, but we have had that option available to Hoosiers for 28 years. So there would have to be a pretty compelling argument about why you would take away that option. I don't think it'd be the first thing you'd want to offer anyone as an option, and certainly not what I'd want to see in a state issued form. And there's consensus and agreement about that, but it is something that's been available to people for 28 years. So there is some interesting discoveries about, people kind of specialize or are really more familiar with some aspects of the code than others. And that's been an interesting conversation. A lot of discussion about can you orally revoke things or not orally revoke things? And we've been advocating that oral revocation would be preferable rather than requiring people to do that in writing. And, you know, lots of little nuances to the bill that I'm hoping we get to a point where it's clean and people are happy with where it's at and we can move it forward. And certainly there is definitely growing support from a range of stakeholders for the version that was just introduced. I think the only other thing I'm going to say about legislation is a little bit of a detour, although it's relevant. I told you that the Indiana Palliative Care and Quality of Life Advisory Council also made recommendations about access to palliative care. There is a second bill that's been introduced, House Bill 1199, that actually includes a definition of palliative care. Interestingly enough, there was a definition in the bill that authorized the council, but it sunset when the council ended. So there's no like official definition of palliative care in our statutes, and that's relevant for lots of reasons, including what we can do with Medicaid and regulatory issues and rulemaking. So we are hopeful that this bill that includes a definition of palliative care will actually pass. And the other piece of this bill is it would allow hospice providers to provide community-based palliative care. So that could potentially expand access, particularly in communities where there are not, you know, robust hospital teams, even let alone people available to do community-based palliative care. So that was one of our recommendations from the council. So it's really exciting that there are two pieces of legislation that are moving forward this year that reflect the work of that group. Okay. I've mentioned POST and POLST a couple times, and I am really hoping you all know what I was talking about, but just in case you don't, I will do a quick, 30-second overview of POST, which is the physician orders for scope of treatment. This is a tool we have available for Indiana that's based on a national model called POLST, basically the exact same thing. And what it is are orders that reflect a person's preferences. There are medical orders that are actionable as soon as the form is signed. And it has to therefore be signed by a physician or advanced practice provider, as well as the patient or their legal representative. It contains orders around around cardiopulmonary resuscitation, medical interventions, which include things like intubation and hospitalization and ICU care, antibiotics, and artificial nutrition. The other thing I'll say about POST is that it is like advanced directives. It is an advanced care planning tool, but it is not an advanced directive. It's a medical order form, and it is only available to people with advanced chronic progressive disease or frailty or terminal conditions. So it is really for a subset of patients who are very near the end of life. And the reason I'm sharing this with you is because since I've last presented before this group, there have been some changes to the Indiana POST Act, and I wanted to make sure that this group was aware of them. In the 2018 session, we had a bill that went through successfully to do a variety of things that really in some ways represented cleanup to the original POST bill that passed in 2013, kind of questions that had come across to us over the years and issues that had arisen. So it expanded the list of who was required to honor the orders on POST, like an example of a group that was originally not included in the list of who was required to honor were dentists. There was no intention to snub dentists. We were not trying to leave them out, but we got a question actually through one of our Fairbanks faculty, like, why aren't dentists listed? Like they're not sure if they can honor it or not. So we expanded that list to include those individuals. Home health workers was another group, group home workers as well, because they were just groups that weren't on there, and they felt like, well, if I'm not on there, then they want me to do CPR when somebody codes, even if they have an order. It was very convoluted, but I think we cleaned it up. I also clarified that English is the only valid version of the form, and that might seem like, well, gee, of course it'd have to be in English, right? Because who's going to follow the orders? Healthcare providers like emergency medical responders. But I had enough conversations with people who were really excited that they had used the state Spanish version that was put out there for educational purpose. They used it with a patient and sent them home with it. And I thought, well, what's going to happen when they call 911? Like, what if the EMT doesn't speak Spanish? Like, it just seemed strange to me. And we couldn't get that fixed, so we just added that in here so that it's clear it's the only valid version, which I think now we've solved that problem. It also identified which elements must be filled out on the POST form in order for it to be valid. I have received calls over the years from people who say, you know, the physician didn't write her license number down, so we don't think we can honor it. And that is not a required element. Furthermore, you can look up a physician license number and add it if the physician doesn't. If there's no requirement, the physician write their own license number. So we clarified what elements were required in order for the form to be valid, which included the patient's name, the date, code status orders, the Section A orders about cardiopulmonary resuscitation, and the signatures. It could be nothing else in there, and it's still valid by Indiana statute. We also clarified that people who were physically unable to sign could authorize someone to sign on their behalf. That was a request that came from the hospitals, actually. We also added in a provision that allows our emergency medical responders to honor out-of-state forms. And we clarified the conditions under which a healthcare representative could override a patient's decisions on POST. So when can a healthcare representative make decisions that are counter to the decisions the patient made on POST? And that's when they're consistent with the patient's expressed or implied intentions. You heard that language a few minutes ago when I was talking about what we're hoping to include in the advanced directive, new advanced directives. And then the biggest change was that advanced practice nurses and physician assistants were added as authorized signers of the form. And that was something that was just frankly not even it was a no-go in 2013 when the original legislation was introduced. And in 2018, we actually had numerous physician groups testify in favor of adding and expanding the scope of who was able to sign. Additionally, I don't see my, I don't think I did that fade in, but we'll take it. The other thing that went through in 2018 was that we clarified what happens when someone doesn't have a legally appointed representative. And many of you may be aware that previously in Indiana, we had a list of people who were able to make decisions for a patient if the patient had appointed someone, their spouse, adult children, siblings, and parents, right? And the problem was that was a committee. There was no hierarchy there. It was unclear if there was disagreement, who had the authority to overrule, who do you go to? What happens if there are 15 people who fit those categories? How do you manage that? And there were all sorts of different interpretations about how to use that. Hospital attorneys trying to make sense of this came up with rules that they used internally, but frankly, it was sort of a mess and created a lot of additional work. So in 2018, in addition to the changes to the POST, there was what I would say is a pretty significant change to our default surrogate statutes, and that is the addition of a hierarchy. So now if there is no person who's legally appointed as either a healthcare power of attorney or a legal representative, and if there's no legal guardian appointed, then the spouse is the person who has the top priority in making decisions. I will tell you, most people thought that's what it was before. So in fact, Amber Comer, one of faculty at IU, had done research in which she surveyed physicians, and they largely thought that you talk to the spouse, right? Well, that makes sense, but it wasn't what our laws say, and now our laws actually line up with practice. So if there's no spouse, it goes to adult child or the majority of adult children. You notice we haven't completely fixed the committee issue. We've clarified a majority can rule. That was not there before. Yes, sometimes there are two children and they disagree, and so we haven't solved 100% of the difficult situations, but this, from all reports, has dramatically reduced the amount of conflict around who gets to make decisions. And then I'm going to point to the bottom of that hierarchy, because what we also were able to add were the nearest other adult relatives, right? So you've all taken care of those patients who don't have kids, they don't have spouses, and they are really, you know, they have a niece. Well, now that niece can make decisions. Okay? Before, there wasn't a way to do that without theoretically her, you know, if the patient lacked capacity, that niece would have to go to court. And then we also added, if there are no relatives at all, an adult friend. And we clarified, what that meant. So it's somebody who had regular contact with that person, knows the patient well, is familiar with their activities, health, and religious or moral beliefs. The other category that you don't see here but is on here, it's such an unusual situation, it's not on this handout, are if somebody's a member of a religious order, and that specifically means a nun or a monk or a priest, then their religious superior can make decisions. But that does not mean that somebody's priest can make decisions for them, just to clarify, if they're not a nun or a monk or a priest themselves, a member of a religious order. There are a lot of resources to learn about advanced directives, and I want to make sure that this group is aware of them. So the Indiana State Department of Health has what's called the Advanced Directives Resource Center online, and they've done a really nice job of creating materials, educational materials, patient-oriented materials. It's a great resource, and I encourage you to check it out because it has all the state-approved forms as well, if you had any question about whether you're using the right form. Additionally, I am part of the Indiana Patient Preferences Coalition, and we maintain a website called indianapost.org. We have a variety of resources for both patients and healthcare providers on here, including videos and brochures and handouts. And so this is another source of information. You can also go there to download the form if you don't have one handy and you can't find it. Another thing that we were able to add very recently that I want to make sure this group knows about are translated versions of the Indiana Post form. And we ended up with translations in 7 languages: Arabic, Burmese, Chinese, French, Korean, Spanish, and Vietnamese. This is based on the languages that are most commonly spoken if your English is not the first language for a person in the state of Indiana. And we also added in an introduction that is both in English and in Spanish, so that you know what they're reading, or family members are bilingual, they can follow along. And then the form itself is translated into Spanish. The signatory lines, which are not shown here, are blocked off and say for educational purposes, so it cannot be signed. So we are really happy to be able to offer this. We were fortunate that the state of California, who has their own version of POST, the POLST form in California, they have like 12 languages on their website. We were able to work with the companies that California had already worked with to do the translations of our forms. So we have some confidence. I don't know, I can't read Korean, so I can't verify the accuracy, but we hired a company that specializes in this kind of translation and has already done this work for California, and California had actually done quite a bit of work on vetting all of the translations. So we feel really good about these versions and hope that they'll be useful to you. As I indicated previously, POST is based on a national model called POLST, and we actually belong to an organization called National POLST. And this group is responsible for maintaining standards nationally for advocacy and education related to POST. And we are an endorsed state, meaning we meet all of the national standards. We're one of 23 endorsed states. As you can see from this map, the different shades of pink represent the kind of the endorsement status, and there are a couple states that have endorsed a very long time, California and West Virginia specifically. But nationally, this is really growing to be the standard of care. There are programs in virtually every state. You'll see a few white states, and those are states that are unaffiliated, either because they have opted out of participation or because they have programs that are inconsistent with the national standards in ways that make it really difficult to say we're talking about the same thing as what is happening in the rest of these states. There are a ton of resources on National POLST as well, lots of education, research, as well as frequently asked questions and contacts for people if you have any need to reach out. If you have a question about, gosh, I have someone, a patient from Illinois, you can go on this site, click on Illinois, and learn about the Illinois program. Additionally, the group has spent a lot of time creating standards for use, and they recently released new standards for appropriate use that are we actually have criteria in our statute about who's eligible for the Indiana POST, and they line up well with the national appropriate use definition. And basically they say that POST is intended for patients who are considered to be at risk for a life-threatening clinical event because they have a serious life-limiting medical condition which may include advanced frailty. And then they further specify that a person is POST eligible if the healthcare provider, meaning typically the physician or advanced practice provider, would not be surprised if the patient died within 1 to 2 years. So this is new guidance about intended population that may be helpful to you as you think about, who do we use POST with and when is it relevant for the patients that I take care of. Additionally, in an effort to move us towards national standardization, the National POLST undertook a National POLST Form project 2 years ago and solicited feedback from every single state, groups in every single state, to create a national form with the goal of every state eventually adopting the national form, which would make it a lot easier to have a consistent national standard when you think about education and training, and then increase the transferability of preferences documented on POLST across state lines. So this is a really exciting project, and there was a tremendous amount of work, and certainly our group in Indiana provided feedback multiple times to help shape the way it looked. It's not super different from Indiana. I think it is possible we might be able to adopt this, but it is not a top priority right now. So. In my introduction, Robin indicated I chair the National POLST Research and Quality Assurance, and I just want to let you know that there is members who are part of National POLST who are thinking about quality assurance, and we've created a quality indicators toolkit to try to support organizations that are using POLST and are interested in doing QI around it. And this has been a really interesting process. I think one of the common challenges that I see is that people want to create essentially, they ask important questions, but basically what they're posing is a research study that would require like 4 years and $3 million and 3 biostatisticians in order to answer the question. So we're trying to help people let's do something that's realistic for your organization and your resources. So we have sort of leveled measurement approaches for the different indicators. So if it's a hospice that wants to check use, there's a really low key way they could actually do that wouldn't take an enormous amount of resources or even expertise and data analysis, for example, to answer. I'll also mention there was a national debate about whether artificial nutrition orders belong on the POLST form, and in fact one state had opted to remove it, and the national group convened, reviewed the data that was presented and discovered some frankly flaws in the analysis. I led that work, and finally ended up concluding that we thought that this was an important part of a conversation about goals, values, and preferences, particularly in the context of life-limiting conditions. So we stick with the argument that we think this is an important discussion and important options to include on the POLST form. So now I'm going to move to some of the research that I'm involved in the state of Indiana, just so you know what's going on, because there is a tremendous amount happening. And I'm mostly giving you what I'm doing, but there are other people who are doing work. So the first one is a project that Robin mentioned in my introduction, the Approaches Pragmatic Clinical Trial. So I've got Approaches in there twice. I wanted to make sure I defined the acronym, because the last time I gave a presentation, I just said approaches, and then my mind went blank about what the acronym meant. So I think I did overkill here. But this is a trial in which we're working with 200 nursing homes to implement an advanced care planning specialist program. And basically the nursing homes are going to take ownership of the implementation, and that's what makes it pragmatic. That's what pragmatic means. It's not a traditional research trial where we send in research assistants and interventionists we trained who carefully follow our protocol. This is saying, like, here's the training and an approach we created, and And we're going to hand it over to you and we'll help support you, but we want you to implement in a way that makes sense for your organization. We're working with 3 different companies that own that combined total of 200 nursing homes. And we have funding through the National Institute on Aging for this research. And you can see here, I'm pictured with my co-principal investigator, Kathleen Unroe, who's a geriatrician and associate professor in the School of Medicine, as well as an investigator in the IU Center for Aging Research at Regenstrief. Our program and our goal, our program is called the Advanced Care Planning Specialist Program, and our goal is to offer every single resident in those 200, actually only 100 will be in the intervention, every single resident in those 100 buildings the opportunity to engage in advanced care planning. And actually our focus is really on people with dementia. So when we say resident, we're really talking about the surrogates who make decisions on behalf of those residents. Between 60 to 80% of nursing home residents have some level of cognitive impairment. We will have key members of the nursing facility team who are trained in advanced care planning. And these individuals will be called advanced care planning specialists, and they'll serve as internal champions who will engage in conversations, work on policies and procedures, promote strong communication and education within the facility. The companies have agreed to dedicate 20% FTE, so 10 hours a week for each specialist, which is pretty remarkable and reflects really their commitment to this as part of their mission. Advanced care planning is not something you can just throw on top of your job. If you've already got a full plate and someone says, hey, do you want to take on advanced care planning? I hope your first response is yes, and then your second response is, what are we taking off my plate? Because you can't just do this as an add-on to your current work. It takes dedicated time. It doesn't take tons of time, but if you don't have space in your schedule for it, it will not happen. We were really lucky to be able to work with the state of Indiana and the Division of Aging and adapt part of our training that we created for the Approaches trial for use with nursing facilities in Indiana. And the state of Indiana agreed to add advanced care planning to something called the value-based purchasing formula. So nursing homes are incentivized to engage in quality improvement activities, and there's a formula that's used to determine how many points they get, up to 100 points, and 100 points is the total amount you could possibly get back. 5 of those points are now advanced care planning training. So if they have somebody trained in their building for 9 months of the year, they get 5 points towards their value-based purchasing formula, and they get basically financially incentivized to have someone in the building with training in the basics of advanced care planning. So we were able to adapt our training for that group. We did a survey. We've had 1,087 people complete the training, and we did a survey and asked, does the training have practical value for your professional role? I will tell you, I don't know that I've ever done a survey where 99% of people had said, yes, this was important and meaningful to me. So we were really excited about that. And interestingly, a lot of nursing homes had more than one person complete the training. I don't think this completely shows that, but most of them had more than one person engage in the training, and some had 4 or more. A lot of enthusiasm for it, and a majority of nursing homes had someone trained, 501 out of 534. We also took that training and used some funding that I have through the Walter Cancer Foundation to adapt it for a more general population. And we will be making this training available through the Regenstrief Institute website. And it will allow people who are interested in getting additional training in advanced care planning to complete these modules and learn more about the fundamentals, about patient-centered goals of care. And this will be an existing resource that will be available that people could also upload into their learning management systems within their organizations. If they talk with me, we can make that happen. So we're really excited to have been able to further adapt it for this purpose. Additionally, there are several research grants that are underway studying advanced care planning and POLST aside from approaches. So one I'll highlight is Dr. Lexi Torkey's POLST Facilitation in Community Dwelling Older Adults. I'm part of this team, and I see Dr. Torkey right back there. She's also faculty within the Fairbanks Center for Medical Ethics and director of the Evans Center. And she is, we are basically looking at the use of POLST within the community care setting. So what happens when we have people facilitate these conversations with patients who are receive care in the community, and what are the outcomes associated with that. So it's a really exciting project that's just getting started. And I also have a study that's just ending that's focused on the quality of POLST decisions in the nursing home. And this is funded by the National Institute of Nursing Research. And, you know, essentially our question is, so we've been successful in implementing POLST in nursing homes. And in fact, we know from some of the work that we did in support of this project that a majority of nursing homes in the state are using POLST for their patients, Indiana Post. But the question is, you know, are the orders on file really reflective of that person's current preferences? And there are a lot of factors that might influence that. So we designed a study in which we went to nursing facilities. We did chart reviews to identify people who were appropriate. We looked both at facilities where they use POLST and facilities where they don't, and looked at who made the decisions that were recorded. We did a random selection out of the group who were eligible. We screened them to make sure they could consent and participate. And then we did interviews with them using a model called Respecting Choices. We interviewed 275 residents and surrogates where there was a POLST form on file. And then we also looked at 83 residents and surrogates who did not have it, where there was no POLST form on file for the resident. Because we were interested in, you know, does POLST do a better job than standard practice at accurately reflecting current preferences? And then we have like 300 other questions we're asking, but what I'm going to share with you right now is that first one. And what we found is that when a resident had a POST, their orders were concordant with their current preferences 59% of the time. When they didn't have a POLST, their orders were concurrent with their preferences 35% of the time. And this was kind of off the charts significant in terms of the difference between these two groups. I would love if that percent on the POST was higher, right? But it is still important evidence that when we use POST, we can do better at ensuring we know and accurately have information about a person's preferences to guide treatment than when we don't use it. So that was an important question we wanted to answer, but clearly there's room for improvement. We also looked specifically at within the POST form, how well the different orders matched up with current preferences. And as you can see, the one that was most accurate were orders around cardiopulmonary resuscitation, 86% of the time. Those were their current preferences. Orders around medical interventions, about 2/3 of the time were accurate or reflective of current preferences, and about the same for artificial nutrition. We're doing a variety of analyses to try and understand what factors contribute to whether or not there's a match between preferences and documentation, so stay tuned, there will be more. We also did qualitative interviews, and some of this will not surprise you, but interestingly, it's the first time anyone has actually examined this question about why is there a mismatch? Why might documentation not reflect current preferences? When we interviewed residents and families about this, there were several things that we heard. One of them is that people's ideas about what they wanted changed over time, right? This is not a surprising thing, but we did hear this as a common theme. Some people also said that they had new information that made them rethink their decision. So something, not just a change, but that they learned something in the course of talking with our research assistants, for example, that hadn't been explained before, that made them rethink their decision. Other people reported that they were influenced by others, like family members. You know, for example, we had one person who said, you know, this isn't what I want for myself, but it's what my daughter wants, and she was there when we were making the decision. I'd rather make her happy, so I'm fine with what you wrote. You know, what's there, but it's not really what I want. Which is interesting because we assume that this is super important to everyone, and maybe it isn't. We also heard about problematic processes, POST forms being handed out in admissions packets and family members filling them out themselves. And then finally, we had people who just couldn't even explain it. They had no insight. They didn't remember filling out the form before. They're like, I don't know. So that's interesting as well. And again, we assume this is super important, but I think there's a subset of people for whom maybe this isn't the most important thing to have their preferences documented and to engage in these kinds of conversations. Our next steps for that project are to do intervention research. And in fact, we have a video that was created with a grant from the Walther Foundation that's available on indianapost.org. And we will be studying use of that video in the nursing facility setting to evaluate how well that improves knowledge and increases concordance and other outcomes. We will we'll be working on that. We'll also be disseminating the findings from the study and finishing our analysis and moving forward into these next steps in the coming months. So I can't believe I actually managed to leave 10 minutes for questions, but in conclusion, there is a lot of work that's ongoing to improve advanced care planning in Indiana and help us have better tools. Tools alone are important. They are not the only thing. We also need people with the skills and training and expertise to engage in these conversations. And that is a really important thing I want to acknowledge. It's not enough just to have a piece of paper. You have to, as a clinician, have some training. You have to understand what the options are, what they mean, how to engage in value-neutral conversations, and support people in making informed, values-based decisions. There are lots of national and local resources that exist to support your practice and educational efforts. And then also, I think I want to highlight Indiana really is, I think, a hub nationally for work in this area. And we have numerous investigators who are doing work to improve advanced care planning and palliative care more generally. And I mentioned Kathleen Unroe and Lexi Torkey. There's also Dr. Greg Sachs I want to make sure I mention as well. And Amber Comer. There are many people doing work in this area, and it's really exciting to see this moving forward. So with that, I have perfect timing with whatever that noise is. So thank you everyone for your attention. I'd be happy to take any questions. What is that?
Have you guys looked at anything regarding age for who can sign so that adolescents have a say?
So under Indiana statute, adolescents can have a POST form, but they cannot by law complete an advance directive. There is work that's happened nationally looking at engaging adolescents in advanced care planning conversations. There's a woman named Maureen Lyon out at Children's National who's done a lot of great work with kids with cancer, with life-threatening cancer diagnoses, or kids with AIDS, and has found really that adolescents clearly have an interest and a need to participate when they're faced with a life-threatening illness. We don't have anyone right now studying this in Indiana. And I'm looking at Lexi to make sure I'm not forgetting something. So yeah, but it is a really important question. And certainly, even though those tools are not officially legally available, you can still engage in conversations about goals and values and work ideally with the parents to have a conversation that allows them to share this information with each other. Because really the best advanced care planning is advanced care planning that happens with not just the patient, but with their important family members and loved ones.
Two of the problems that I think we run into with POST sometimes are when we have a surrogate decision maker who's in a different state, who's not available to physically sign the form, but is willing to do so, and there are clear wishes to express. And I'm wondering if there's any movement toward an ability to do that verbally over the phone, maybe with two witnesses. And the other part of that is if we have someone who desires to fill out a POST who's acting in a surrogate capacity according to the statutory hierarchy, but is not a healthcare representative or healthcare power of attorney. And both of those, I think, would be really helpful to fix.
I agree. So the first question was, what do you do with surrogates out of state? If you have a surrogate who has access to a computer, you can scan it and they can sign it because electronic signatures are valid. So, and more old school faxing, you can do that. And I would recommend that. The statute doesn't authorize verbal phone consent. In terms of the hierarchy, it is true that under Indiana's POST Act, the only surrogate who can sign a POST on behalf of a patient without capacity is a surrogate who has been legally appointed as their legal healthcare representative or power of attorney for healthcare. That is not an accident. And I have probably like a permanent bump back here from banging my head on the wall about that one. I bring this up constantly, and other states actually allow those default surrogates to complete a POST, but the counter argument, which is completely has merit is that because there can be more than one person in a category who is eligible to sign. So if somebody has 7 children and no spouse, all 7 of those children have equal authority. And what happens if every single one of those kids takes mom to the doctor and has a different post form filled out? So that is an ongoing concern, and I think we're unlikely to see a change in that because of the worry about the complexity that would bring in terms of honoring preferences. I honestly don't think it's been a huge issue in other states from my conversations with people across the country, but it's a valid concern, and certainly I think everyone is so relieved that we now have a hierarchy that they don't, like it feels like we're trying to get away from having groups of people be able to make decisions. And I think there's a lot of resistance to moving back in that direction for anything. And that's the unfortunate reality. Again, it's mixed across the country. There are other states that allow the defaults and have similar situations, but I haven't heard it's a huge problem. There are other states like us who restrict it.
Hi, Susan. This is
Equal.
probably a parochial question, but why is Oregon, the state of Oregon, ironically unaffiliated now?
So they have opted not to participate. There was a disagreement. The National POLST organization used to be housed in Oregon through the Center for Ethics for Healthcare, which houses the Oregon POLST program. And when the national program, kind of launched and split and became its own entity, the leaders of National POLST were unwilling to comply with the ethics center's rules around potentially accepting financial contributions from industry. And the National POLST group since they were so new and they didn't want to close any doors because it's not always easy, like is the Lilly Foundation industry, like there's a little complexity, but the Oregon Center for Ethics, Oregon Health and Science University Center for Ethics has never accepted any funding with industry tries there. And so they wanted that same rule to apply. And since the National POLST was unwilling to go there, they didn't feel they could continue to participate. All very political. Shilpi?
Just a quick question. We on occasion get prisoners dealing with terminal illness. Can you just shed some light about rules and regulations on advance directives of that?
That's a great question, and I cannot shed any light on that. I know, when I was I actually was in Oregon before I came here, and I know that that prisoners are not even allowed to sign a DNR order, and I would expect it's the same here, but I actually don't have any specific information because they're wards of the state, and the state has a perceived fiduciary responsibility. And there are lots of reasons why that's not permitted. There are people working nationally on issues related to prisoners and end-of-life care, and I'm hoping that moving forward there'll be more conversation about that, because we have actually an aging prison population and actually a significant geriatric population, and there are a lot of issues of providing care, safe care for prisoners with dementia, for example. So I'm hopeful there'll be developments moving forward, because it's a really complicated population, but I do not have any answers for you right now.
So this is a question that we got texted in, Susan.
Great.
It asks, to cancel a healthcare POA in writing, do you have to utilize a special form, or can it be done informally, such as via a letter written and signed by a patient?
I'm going to look at a couple of the attorneys we have here. Do you know? You don't know, Jane? It has to be in writing, and I think it has to be communicated to the person who was a healthcare power of attorney. So I don't think there is a form. In fact, I'm pretty confident there's no form. It just needs to be in writing. So a letter saying, to my terrible daughter, I no longer want you to be my healthcare power of attorney. You are fired. And then it has to be, I'm sure, witnessed. Yeah. But ask an attorney. Ask your attorney.
I think we have time for one more.
Hi,
earlier when you were talking about the default surrogate hierarchy, I think the third one down was a parent. And I just wondered, what if there's two parents and
Yep.
they disagree?
Yeah, same. It's the same issue with the siblings, right?
Yeah.
I mean, we didn't solve, so this is one of the things that has been interesting to me in working with legislation is that it's pretty much impossible to write a law that solves 100% of the problems we encounter. And so pretty early on, I started, because I would get this question about like, what if doctors disagree? Because that never happens, right? So what if there's a post form and doctors disagree? And, I said, we're not trying to solve 100% of problems. But if we can improve the experience of patients and families and healthcare providers and eliminate 70% of the problems, we have gone a long way towards increasing efficiency and towards improving quality of care. So no, you're right. So that can be particularly contentious if you're talking about a minor, but actually may contentious with any age group. So we have not solved all of those problems, and I don't know how we could, right? Like, how do you pick? Because any rule you come up with, someone will come up with 10 scenarios about why that's a problem. All right.
Thank you, Dr. Hickman. We will be at Riley the next 2 months, so we will not be back here until April. Thanks, everyone.